Osteoporosis. What exactly is it? How do we diagnose it? And how do we manage it? So, the definition by the WHO, the World Health Organization, is such that osteoporosis is a reduction in the bone mineral density. Now, what osteoporosis is not is a softening or weakening of bones, which is commonly heard in the clinical setting by a whole host of clinicians. Softening or weakening of the bones is associated with vitamin D deficiency and or other malabsorption disorders. And with vitamin D, we are looking at rickets in children and osteomalacia in adults. These are categorically different to osteoporosis. Now, the definition that I spoke of, as per the WHO, has a caveat, and that is the fact that they do not give any weighting to the fact that there is a compromise to the structural integrity of that bone. And I will explain myself in a short while as to why and what I mean by that. Now, osteoporosis, as I said, is a reduction in the bone mineral density. Well, what does that mean exactly? So, to understand this, we need to appreciate a very basic overview of the anatomy, and that being of the long bones, i.e. the femur being a primary example. So, when we look at the long bone, the femur, the outer layer is your periosteum, deep to that is the endosteum, and deeper to that is your trabeculae. Now, the trabecular network essentially is a scaffolding. This scaffolding is perhaps likened to the honeycomb structure in a Cadbury's Crunchy Bar, for example. And what we find is that there is a reduction in the amount of this scaffolding. And that's what we mean by a reduction in the bone mineral density. So what therefore happens is that the inner aspect of the bone is reduced in terms of its percentage and quantity, and therefore that weakens the bone. Therefore, the bone is more prone to fracturing. So appreciate this is not a softening of the bone, as I said, associated with vitamin D deficiency. How do we diagnose osteoporosis? Well, with osteoporosis, what happens is that we send the patient for a DEXA scan, a dual energy X-ray absorptiometry. And in this scan, what we do is we scan either a lumbar vertebra or the iliac crest of the pelvis bone, or otherwise sometimes the small bones of the hand, i.e. the carpal bones. And what we do is we compare these, and we compare the density from these results, the patient's results, to either a patient of the same age, or we compare the bone mineral density of the patient to that of a 30-year-old, of course, the same anatomical region being compared, of course. When we compare it to the patient's score with another patient of the same age, that gives us something known as the Z value. Now, the Z value holds no clinical significance. What we go by is the T value. And the T value is derived from comparison and calculations between the patient and that of a 30-year-old in the same anatomical region again. Now, the T value is given as being greater than -1, -1 to -2.5, and less than -2.5. And the value greater than -1 is deemed as being normal bone mineral density. A value between -1 and -2.5 is referred to as osteopenia, which is a precursor to osteoporosis. And finally, a value less than -2.5 is deemed as being osteoporosis. And therefore, we will definitively say that this patient has osteoporosis. So clinically, when do I suspect a patient has osteoporosis or a reduction in their bone mineral density? Well, when they experience what we call fragility fractures. So what exactly is a fragility fracture? By definition, if a patient falls from a height that is equal to the patient's height and incurs a fracture, that is deemed as a fragility fracture, because somebody falling from a height equal to their height should not incur a fracture. Now, in clinical practice, a similar concept can be applied to a patient, for example, stubbing their toe. Again, the force generated in a simple stubbing should not lead to a fracture, but if it does, then again that should raise clinical suspicion for osteoporosis or otherwise osteopenia. Now, I said earlier about the caveat associated with the compromise in the structural integrity of the bone, the reason being because we will see patients who experience fragility fractures, yet they are by definition not osteoporotic as per the WHO guidelines, i.e. their T-score is greater than -2.5. Now, they may well be osteopenic or otherwise even normal in exceptional circumstances, but that's where the caveat lies. Now, in terms of management, the first thing we do is conservative non-pharmacological approaches, and the most important is recommending some supplementation, so foods and diets that are richer in calcium, vitamin D as supplementation, and phosphorus, because these are the three main things. These are the blood tests that we would conduct to determine whether or not the patient has some form of compromise to their bone mineral density. So your blood tests may include the likes of bone profile, including calcium, phosphate, and as well as thyroid function tests, parathyroid hormone, and your androgens, amongst a whole host of others. Resistance exercises are absolutely of paramount importance here, because stress, as per Wolff's law, the body lays down bone in the line of physical stress, and this it does so by a process known as mechanotransduction. And finally, pharmacological intervention includes the likes of alendronic acid. These are referred to as categorically as bisphosphonates, and there are some challenges with bisphosphonates, including side effects of dyspepsia, as well as rarer complications such as osteonecrosis of the jaw. So therefore we exercise the use of bisphosphonates with an element of caution, including periods where we have time off from using the medication. So there we have it, osteoporosis, what exactly it is, how we suspect it, diagnose it, and manage it. Thank you for watching.